Good evening, Dr. Phil here. Today we'll be discussing on Class 1 antiarrhythmic drugs. Class 1 antiarrhythmic drugs block sodium channels by binding to sites in the alpha subunit. General effects: reduction in maximum rate of depolarization during phase 0 of the cardiac action potential, reduction in conduction velocity, reduced excitability and automaticity, inhibition of arrhythmias caused by abnormal automaticity or re-entry, membrane stabilizing effects, and local anesthetic properties. Class 1 antiarrhythmic drugs are further subdivided into Class 1A, 1B, and 1C according to the specific characteristics of the sodium channel block that they produce. The electrophysiological differences are subtle and relate to the different affinity of drugs to channels in a resting, open, and refractory state, amongst other complexities. Class 1A antiarrhythmic drugs. They work by moderate sodium channel blockade, antagonization of fast influx of sodium ions. This reduces conduction velocity of the AV node and His-Purkinje system, prolonged repolarization. They possess varying antimuscarinic and sympathomimetic effects. Examples include quinidine, disopyramide, procainamide, and archmalin. Cardiac effects include moderate decrease in Vmax, variable effects on action potential duration, increased refractory period, and widened QRS. Examples of indications include for treatment and prevention of SVT, VT, and atrial tachycardia, and treatment of WPW. There is declining usage due to pro-arrhythmic effects, such as torsade de pointes, resulting in increased mortality especially in patients with ischemic heart disease or poor LV function. Quinidine. This is an isomer of quinine. Its use has declined due to its side effects. It is formerly used in the treatment of atrial, supraventricular tachycardias, and ventricular ectopic beats at 200 to 400 mg orally TDS or QDS. It is a Class 1A antiarrhythmic. It reduces the rate of rise of phase 0 of the action potential by blocking sodium channels. It increases the threshold potential and refractory period, but does not affect the duration of the action potential. It has antimuscarinic and alpha blocking properties. Pharmacokinetics. It is well absorbed from the gut. Oral bioavailability is 75%. It is protein bound 90%. Peak plasma levels occur 1 to 2 hours following oral administration. 80% is metabolized by the liver to active metabolites. Metabolites are excreted in the urine. 20% is excreted unchanged via the kidneys. Elimination half-life is 5 to 9 hours. Adverse effects are common. It has a low therapeutic ratio. Adverse effects are unacceptable in up to 30% of patients. Cardiac side effects include heart block, sinus tachycardia due to vagolysis, ventricular arrhythmias, prolonged PR interval, widened QRS and prolonged QT interval, hypotension. Effects are additive with other cardiodepressants. Non-cardiac adverse effects include synchronism, which is central nervous system toxicity characterized by tinnitus, blurred vision, impaired hearing, headache and confusion, anticholinergic effects, GI symptoms, hypersensitivity, rash, thrombocytopenia, hemolysis, and agranulocytosis. Drug interactions. It increases digoxin levels by displacing it from binding sites and reducing its clearance. Phenytoin reduces quinidine levels via hepatic enzyme induction. Cimetidine increases quinidine levels via hepatic enzyme inhibition. Depolarizing and non-depolarizing muscle relaxants increases quinidine's effects. Archmalin is a quinidine-like drug. It is a Class 1A antiarrhythmic. It is used in the treatment of atrial fibrillation in patients with WPW syndrome and to challenge the conduction system of the heart in cases of bundle branch block and syncope. Abnormal prolongation of the His ventricular interval has been taken as a proof for infrahisian conduction defects tributary for permanent pacemaker implantation. Archmalin inhibits intraventricular conduction and prolongs AV conduction time. Disopyramide. It is used as a second-line agent in the treatment of SVT. Ventricular rate should first be controlled with beta blockers or verapamil when disopyramide is used to treat AF. It is a second-line agent to lidocaine in treating ventricular tachyarrhythmias. Presentation includes tablet and solution, 10 mg per ml. Oral dose is up to 800 mg daily in divided doses. IV dose is 2 mg per kg over 30 minutes, up to 150 mg, followed by an infusion of 1 mg per kg per hour, up to 800 mg per day. Mechanism of action. It is a class 1A antiarrhythmic. It reduces the rate of rise of phase 0 of the action potential by blocking sodium channels. It increases threshold potential, refractory period, and duration of the action potential. It has less action on the His-Purkinje system than quinidine. It has greater anti-muscarinic and negative inotropic effects. Pharmacokinetics. It is well absorbed from the gut. Oral bioavailability is 75%. It is partially metabolized in the kidney. One metabolite has marked anticholinergic effects. 50 to 80% is excreted in the urine unchanged. Elimination half-life is 4 to 6 hours and increases significantly in patients with renal or cardiac failure. Adverse effects includes AV block, VT, reentrant arrhythmias, prolonged QT, torsade de pointes, reduced myocardial contractility, cardiac failure and cardiogenic shock, and hypotension. Non-cardiac effects includes anticholinergic effects and GI irritation. Next is procainamide. It is used to treat both SVT and ventricular tachyarrhythmias. It is as effective as lidocaine in terminating VT. It is rarely used in the UK and available only via special order. Oral dose is up to 50 mg per kg per day in divided doses. IV dose is 100 mg slowly up to a maximum of 1 gram and may be followed by an infusion of 2 to 6 mg per minute, with ECG monitoring for widened QRS complex or PR interval prolongation. Mechanism of action. It is a class 1A antiarrhythmic. It reduces the rate of rise of phase 0 of the action potential by blocking sodium channels. It increases the threshold potential and refractory period. It does not affect the duration of action potential. It has anti-muscarinic and alpha blocking properties. It has similar effects to quinidine but is less vagolytic. Pharmacokinetics. It is well absorbed from the gut. Oral bioavailability is 75% with a protein binding of 15%. Procainamide is metabolized in the liver by amidases and by acetylation to the active N-acetyl procainamide. Slow acetylators are more likely to develop side effects. 40 to 70% are excreted unchanged renally. Half-life is 3 to 5 hours, thus necessitates frequent administration or slow-release formulations. Adverse effects have limited its use. Cardiac adverse effects include hypotension, vasodilation, reduced cardiac output, heart block, increased ventricular response rate when used to treat SVT, prolonged QT, and torsade de pointes. Non-cardiac adverse effects include drug-induced lupus erythematosus syndrome with a positive anti-nuclear factor in 20 to 30% of patients, gastrointestinal upset, fever and rash, reduced antimicrobial effect of sulfonamides by the production of para-aminobenzoic acid and agranulocytosis. Class 1B antiarrhythmic drugs. Mechanism of action is via mild sodium channel blockade. They reduce conduction velocity and shortens repolarization. Examples include lidocaine and mexiletine. Cardiac effects. There is mild decreases in Vmax. Class 1B drugs have much less effect on conduction velocity in the usual therapeutic doses. There is reduction in action potential duration and refractory period. QRS is unchanged. Examples of indications. For prevention and treatment of certain arrhythmias, particularly associated with ischemia, such as premature ventricular contractions, ventricular tachycardia, and ventricular fibrillation. Lidocaine. Lidocaine is used to treat sustained ventricular tachyarrhythmias, especially when associated with myocardial ischemia, as inactivated sodium channels predominate, reentrant pathways, cardiac surgery, digitalis toxicity, resistance to DC cardioversion. Lidocaine's antiarrhythmic effects are reduced by hypokalemia and increased by hypoxemia, acidosis, and hyperkalemia. Other indications of lidocaine includes as local anesthesia, for example in infiltration anesthesia, IVRA, epidural, subarachnoid block, nerve blocks, topical anesthesia, etc. Onset is rapid by all routes, dose depends on the block. Duration of action for 1% solution is about 1 hour and increases to 1.5 to 2 hours if adrenaline is added. Lidocaine is also used to depress laryngeal and tracheal reflexes, for example during laryngoscopy. The dose is 1 to 2 mg per kg IV, 2 to 5 minutes prior to intubation or extubation. Lidocaine reduces muscle pains and potassium increases after succinylmetonium. Lidocaine is used as an analgesic as an adjunct in general anesthesia. 4 to 10% lidocaine has been used instead of air to inflate the tracheal tube cuff to reduce post-operative sore throat and hoarseness. Lidocaine is also used in the treatment of chronic pain. Presentation. The IV solution is 1 to 2%. For indications other than arrhythmia treatment, lidocaine comes in solutions of various concentrations ranging from 0.25 to 4%, sprays 10%, gels 1 to 2%, ointment 5%, and amla cream, which consists of prilocaine-based 2.5% and lidocaine-based 2.5% as an oil-water emulsion. Adult dose. In the treatment of arrhythmias, lidocaine is only given intravenously. Initial intravenous dose is 1.5 mg per kg over 2 minutes. This may be repeated after 5 to 10 minutes to a total dose of 3 mg per kg if necessary, or be followed by an infusion. Effects after the initial bolus dose last about 20 minutes. IV infusion is needed to maintain an antiarrhythmic effect. Avoid rapid boluses at more than 50 mg per minute. An example of an intravenous infusion rate regime is 4 mg per kg per minute for 30 minutes, followed by 2 mg per kg per minute for 2 hours, and 1 mg per kg per minute thereafter. Reduce infusion rate if hepatic blood flow is reduced as hepatic metabolism reduces. Ensure continuous ECG and BP monitoring during infusion. The dose should be reduced by 50% if there is reduced clearance, for example, due to reduced hepatic blood flow, for example in the elderly with congestive heart failure and after myocardial infarction, in patients with liver disease, in patients receiving beta blockers or cimetidine. Mechanism of action. Lidocaine is a class 1B antiarrhythmic. It reduces the rate of rise of phase 0 of the action potential by blocking inactivated sodium channels. It increases threshold potential. It reduces repolarization during the phase 3 period. This reduces the duration of action potential and refractory period. There is reduced normal and abnormal automaticity. There is reduced spontaneous depolarization of the ventricles during diastole, and there is increased threshold for ventricular fibrillation with minimal hemodynamic effects. Lidocaine also acts as an amide local anesthetic. Onset of action for IV route is less than 1 minute. Duration of action via IV route is 10 to 20 minutes. Kinetics. Unionized portion is 33%, protein bound is about 70%, pKa is 7.9, partition coefficient at 36 degrees is 110. Steady state would be reached after about 6 hours if there is normal hepatic function in the absence of a loading dose. Metabolism. 95% of an injected dose undergoes hepatic metabolism and is excreted renally. Active metabolites includes MEGX, which is monoethyl glycine xylidide, and GX, which is glycine xylidide. Excretion is via the urine. Elimination half-life is about 90 minutes. Adverse effects of lidocaine. CNS effects are apparent when plasma levels exceed 4 micrograms per ml, which consists of circumoral tingling, dizziness, tinnitus, paresthesia, anxiety, confusion, drowsiness, dysarthria, tremor, coma, and seizures. Cardiac adverse effects are apparent when plasma levels exceed 10 micrograms per ml, consists of unresponsive hypotension, bradycardia, AV block, myocardial depression, asystole. Cardiac side effects are potentiated by hypoxemia, acidosis, and hypercapnia. The maximum recommended dose is 3 mg per kg without adrenaline and 7 mg per kg with adrenaline. Toxic plasma levels are that exceeding 10 micrograms per ml lidocaine. Management of LA toxicity. Recognize the above-mentioned signs and symptoms, stop injecting the local anesthetic and call for help. Resuscitation as per ALS guidelines. Maintain the airway. If necessary, secure it with a tracheal tube. Give 100% oxygen and ensure adequate lung ventilation. Hyperventilate to increase plasma pH to compensate for metabolic acidosis. Establish IV access. Control seizures with benzodiazepines, thiopental or propofol. Assess cardiovascular status throughout. Draw blood for analysis. However, do not delay definitive treatment to do this. If circulatory arrest occurs, start cardiopulmonary resuscitation. Manage arrhythmias according to ALS protocols, recognizing that arrhythmias may be very refractory. Avoid using LA to treat arrhythmias. Consider cardiopulmonary bypass if available and lipid emulsion. If there is no circulatory arrest, use conventional therapies to treat hypotension, bradycardia and tachyarrhythmias, and consider lipid emulsion. The dose of intralipid. The initial IV bolus injection is 20% lipid emulsion at 1.5 ml per kg over 1 minute, followed by an intravenous infusion of 20% lipid emulsion at 15 ml per kg per hour. After 5 minutes, give a maximum of 2 repeat boluses at the same dose if cardiovascular stability has not been restored and an adequate circulation deteriorates. Leave 5 minutes between boluses. Continue infusion at the same rate, but double the rate to 30 ml per kg per hour at any time after 5 minutes if cardiovascular stability has not been restored or an adequate circulation deteriorates. Continue infusion until stable and adequate circulation is restored, or maximum dose of lipid emulsion has been given, which is 12 ml per kg. Arrange safe transfer to a clinical area with appropriate equipment and suitable staff until sustained recovery is achieved. Exclude pancreatitis by regular clinical review, including daily amylase or lipase assays for 2 days. Lidocaine is contraindicated in hypersensitivity, heart block due to risk of asystole. Lidocaine is no longer the first-line drug in pulseless VT or VF during cardiac arrest. Next is mexiletine. This is an analog of lidocaine with similar effects on ventricular tachyarrhythmias. It has similar indications to lidocaine in the treatment of arrhythmias. The IV formulation is a colorless solution containing 250 mg mexiletine hydrochloride in 10 ml. The dose is 100 mg to 250 mg IV over 10 minutes, followed by 250 mg over 1 hour, then 250 mg over 2 hours, then 30 mg per hour after. Mexiletine is also available as modified release oral formulation. The dose is 400 mg orally, followed by 200 to 250 mg TDS or QD. Mechanism of action. Mexiletine is a class 1B antiarrhythmic. It reduces the rate of rise of phase 0 of the action potential by blocking sodium channels. It increases threshold potential and reduces repolarization of the phase 3 period. This reduces duration of action potential and refractory period. Pharmacokinetics. Oral bioavailability is 90%. There is minimal first-pass metabolism, about 10%. There is good absorption from the upper part of the small bowel. Plasma protein bound is 65%. Volume of distribution 6 to 13 liters per kg. 80% is metabolized in the liver to inactive metabolites. Up to 20% is excreted unchanged in the urine with an elimination half-life of 6 to 10 hours. Adverse effects. Mexiletine has a low therapeutic ratio. Side effects are common, such as sinus bradycardia, supraventricular and ventricular tachyarrhythmias, hypotension, nausea and vomiting, altered bowel habit, confusion, diplopia, dysarthria, paresthesia, seizures, tremor and ataxia, thrombocytopenia, rash, jaundice and hepatitis. Phenytoin is also a class 1B antiarrhythmic and will be discussed in a future video. Class 1C antiarrhythmics. Mechanism of action is via marked sodium channel blockade. This reduces conduction velocity. Examples include flecainide and propafenone. Cardiac effects include marked reduction in Vmax, variable effects on action potential duration and refractory period, and widened QRS. Examples of indications for treatment and prevention of SVT, junctional tachycardias, ventricular tachyarrhythmias with or without an accessory pathway. Although effective in chronic AF, these drugs are reserved for life-threatening arrhythmias. They are pro-arrhythmogenic, especially in patients with myocardial ischemia or poor left ventricular function. Flecainide. This is a procainamide derivative. It has amide, local anesthetic, and class 1C properties. It is used in the treatment of atrial and ventricular tachyarrhythmias, including WPW syndrome. IV flecainide usually restores sinus rhythm in acute AF and is useful prophylaxis against further episodes of AF. Oral dose is 100 mg BD, maximum 400 mg daily. The IV dose is 2 mg per kg over 10 to 30 minutes to a maximum of 150 mg. Infusion is 1.5 mg per kg per hour, which is reduced to 100 to 250 micrograms per kg per hour for up to 24 hours. Maximum dose in one day is 600 mg. Mechanism of action. Flecainide reduces fast sodium flux into cardiac tissue. It prolongs phase 0 of the action potential. It has no effect on the duration of the action potential, the refractory period or repolarization. Effects are pronounced on the conducting pathways. There is reduced automaticity. There is dose-dependent widening of the QRS complex. Pharmacokinetics. It is well absorbed from the gut. Oral bioavailability is 90%. Plasma protein binding is 50%. VD is 6 to 10 liters per kg. Flecainide undergoes hepatic metabolism. Metabolites are weakly active. Excretion is renal. 80 to 90% is excreted unchanged. Elimination half-life is 7 to 15 hours. Elimination is prolonged in renal or heart failure. Adverse effects. Flecainide may precipitate pre-existing conduction disorders, especially in SA or AV node disease or bundle branch block, such as VT and AV block. Paradoxical increase in the ventricular rate may be seen in AF. There is increased mortality when used to suppress ventricular ectopic beats following MI. Flecainide increases the risk of ventricular arrhythmias after myocardial infarction, especially in patients with structural cardiac disease. Cardiac failure and increased pacing threshold may occur. Non-cardiac adverse effects include dizziness, paresthesia, headaches, corneal deposits, nausea, vomiting, increased plasma levels in hepatic or renal failure. Flecainide increases concentrations of drugs such as digoxin and propranolol. Propafenone. It is similar in many respects to flecainide. It is used as second-line therapy for treatment of resistant SVT, AF, and ventricular tachyarrhythmias. Oral dose is 600 to 900 mg initially, followed by 150 to 300 mg BD to TDS. IV dose is 1 to 2 mg per kg. Mechanism of action is via reduced fast sodium flux into the cardiac tissue. Propafenone prolongs phase 0 of the action potential. It increases the duration of the action potential and the refractory period. Effects are pronounced on conducting pathways. There is increased threshold potential and ventricular fibrillation threshold. There is reduced automaticity. Propafenone has weak antimuscarinic, beta-adrenergic receptor and calcium channel blocking effects. Pharmacokinetics. Absorption from the gut is near complete. Oral bioavailability is 50% and progresses to 100% as enzymes involved in first-pass metabolism are saturated. Plasma protein binding is more than 95%. Propafenone undergoes hepatic metabolism. Enzymes responsible for its metabolism demonstrates genetic polymorphism so that affected patients may have an increased response. Excretion is via the urine or feces. Half-life is 2 to 10 hours for extensive metabolizers and 10 to 32 hours for poor metabolizers. Propafenone is generally well tolerated. Adverse effects include heart failure, new arrhythmias, worsening of pre-existing arrhythmias, minor nervous system effects, GI adverse effects at high doses. Propafenone may worsen myasthenia gravis and may precipitate bronchial asthma. Use with caution in patients with reactive airway disease. Propafenone may increase the concentrations of digoxin or warfarin. Propafenone may cause agranulocytosis. Contraindications include hypersensitivity, known Brugada syndrome, concomitant ritonavir therapy, bradycardia, asthma, etc. These are my references. Thank you.